So we're going to have our keynote speaker now. As you've heard this morning, antimicrobial resistance is, yes, something we think about in Canada, but really where the action is, where the problem is globally. The biggest burden are in low middle income countries, South Asia, Southeast Asia, Sub-Saharan Africa. So we really need to think about this on a global scale. And I couldn't think of a better keynote speaker to have with us today to give us that broad perspective, a very inspiring individual. So I'd like to welcome Professor Ramanan Laxminarayan, who comes to us as an economist and epidemiologist. He has received his Ph.D. and M.P.H. at the University of Washington. But I think it sounds like he lives in many places in the world and spends a lot of air miles. So he's made it today. It was a close call, but he's with us. He's really a world-leading expert on AMR and how this problem should be understood through the lens of a shared global resources. He plays a major role in the fight against AMR, not only through his work, which are related to the epidemiology level models of infectious diseases, public health, and economic analyses of AMR, but also through his many leadership roles. Notably, he's the founder and president of the One Health Trust, which was previously known as the Center for Disease Dynamics, Economics, and Policy, located in Washington, D.C. and in India. And I know this as the interactive map to go to when you want to see what the AMR rates and what antibiotics are used worldwide. It's really a fantastic resource. He also has multiple academic affiliations, including Princeton, the University of Washington, and Johns Hopkins. He's played a major leadership role in bringing the attention of world leaders and policymakers to AMR, including members of the United Nations General Assembly, the U.S. government. He's also the chair and chair of the board of GARD-DP, known as the Global Antibiotic Research and Development Partnership, which is a global product development partnership that was created by the WHO and that aims to develop and deliver new treatments for bacterial infections. Beyond that, he's also an entrepreneur, and he's founded a company, a startup company called Health Cubed, an award-winning one that aims to bring a wide range of point-of-care diagnostics globally, particularly to low-resource settings. And with this, he's a prolific outreach speaker on TED Talks and with journals and op-eds and whatnot. So with that, I'd like to welcome Ramanan. Thank you.
Good morning, everyone, and thank you, Dow, for the kind invitation to be at McGill. It's been quite a few years since I was here. And, you know, when my kids were small, we used to bring them up to the Laurentians because it was a safe place to be near the lakes and have a fun time, but it's been many years since then. But it's great to be back here. Although, as she said, I came in this morning and I'm leaving this afternoon, so that's just not the best way to visit Montreal. So I'm just going to give a broad overview. It's based on this report that we bring out every 2 years called The State of the World's Antibiotics. And, you know, it sort of just tries to bring things up to speed on what's going on in various aspects. Now, AMR, as you all know, is really a One Health issue. It's broad. And in that sense, you know, the big pieces that I will be missing here are all of the animal health and the environmental health components just a little bit. But let's begin at the beginning. So many countries are struggling with elevated drug resistance. This is a set of pictures that comes out in the Financial Times every year, and we contribute a few of these data points. One is a drug resistance index, which is basically like a stock market index. So to a lay audience on the street, trying to explain MRSA and Klebsiella and ESBLs is just really difficult. So communicating MR has been a major challenge. We calculate this weighted average index, which is done for each country, and you can see India, Turkey are the wrong end of the scale, and Sweden and Germany are closer to where you'd really want to be and I think Canada is somewhere in the middle. And you can see also that with the small reds, that things are actually getting worse progressively in many countries. And of course, in some countries, things are so bad that it couldn't possibly get worse. These are data from the University of Washington. I was just there yesterday. And their estimates are about 1.4 million deaths each year directly attributable to antibiotic resistance, and about close to 5 million deaths associated with antibiotic resistance. Now, deaths are not everything. There's a lot of burden associated with drug resistance, which is buried in many places. But even so, you can see that the total number of directly attributable deaths itself is just a little less than HIV and malaria put together, which are diseases that we think of as being really quite important. We have a global fund for these diseases. We really don't have anything of that kind for AMR. And if you look at it by pathogen, sorry, it's 1.27, almost 1.3. So if you look at it by pathogen, E. coli, staph, and Klebsiella cause the most deaths due to attributable and associated resistance. And the two pieces are, the top part is obviously the associated, and it just is, it's a simple matter of what the counterfactual is, whether you're calling it associated or attributable. 1/4 of deaths related to drug-resistant diseases are because of antibiotic resistance, and that's quite a significant number. It basically means that this is really our biggest barrier to increasing access to treatments, because before people couldn't afford the treatments. Today they're able to afford the treatments, but the treatment doesn't work, which is equivalent to saying they still don't have access to if you don't have access to a drug that works, that's effectively the same as not having access to a drug. So this is the estimated global burden of resistance, obviously with a lot of caveats and holes. It's a function of the underlying burden of infectious disease. It's a function of the levels of resistance. It's also a function of access. If you can afford the more expensive, newer antibiotics, then you don't have as big an AMR problem. So all of these come together to sort of create these kinds of pictures. And in terms of antibiotic consumption, it's highly varied across the world. I forget what it is in Canada, but just to take the US, for example, the states of Alaska, California, or Washington have half the per capita consumption of antibiotics that Sweden does. Not Sweden, of Tennessee. And overall, across the US, average antibiotic consumption per capita is twice that of Sweden. So there's great variation both across countries, but also within countries, which are a function of social norms. It's a function of how medicine is practiced. It's a function of how much, access is there without really any sort of appropriate guidance or diagnostics which are coming in the way. And we do have a significant problem in some places in the world. Turkey stands out, Vietnam stands out. The causes of multi-drug resistance are many, and if you take India as an example, Klebsiella is a leading bug, Acinetobacter baumannii, another important source of these resistant infections. And the mortality odds are not great. If you have a resistant pathogen, you're much more likely to die in hospital, and this is where most people will end up in any case. If you look at trends in resistance, this is very ecological. So each of these circles just represents a study, and the size of the circle is the size. And how steep the curve is how much resistance has been going up just from these aggregate studies. And Southeast Asia, the Southeast Asia region, which starts from India and goes eastward, is really where much of the growth in resistance has been over the last 20 years. Now, it's not as if resistance is a problem all the time. For instance, pneumococcal pneumonia is easily treatable with antibiotics in India, for instance. There's 92% susceptibility to penicillin. Not so in the neighboring countries, but India sort of stands out there. So it isn't as if this is a uniform problem, but it is a problem which is significant enough that it's a significant cause of concern. Now, one of the major age groups that is most affected by resistance are newborns. And the mortality outcomes are much worse in newborns with resistant bugs. So if a newborn has a culture positive sepsis, it's about a 30%, almost a 30% odds of dying. That's pretty high. If it's a gram-negative pathogen, then it's even higher as a risk of mortality. And then if it's ESBL, not treatable, goes up to over 50%, and similarly if it's MRSA. So you can see that already the odds for children, and this is from a study in Tanzania, in one hospital, the odds if you're a child, if you're a newborn with an infection is already not great. And then resistance just makes it a whole lot worse. Now, this is a much, I'll get to that in a second. Amongst all sepsis deaths around the world, so these are the most recent data from two sets of studies. One's called Barnard's. It was run out of University of, it's now at Oxford. It's at the Ineos Institute at Oxford. And the other one is the CHAMP study, which looks at cause of mortality and underlying reasons for mortality in newborns. And you can see without really, you can just look broadly at the slide, and you can see that if the y-axis is deaths from newborn sepsis, the main bug you're worried about is Klebsiella. So Klebsiella today accounts for something like 20 to 25% of all newborn sepsis in all of these different sites. And these are very, very different countries. So there's a consistency there that Klebsiella is really the main pathogen that we're concerned about when it comes to newborn sepsis. This is a slightly old, it's a 7-year-old study from India, from four of the best public hospitals in New Delhi. And again, you can look at case fatality rates in culture-positive sepsis because of resistant pathogens, 69%, 61%, 62%. And even if it's sensitive, it's pretty high. It's about 40 to 50%. So sepsis itself is pretty bad, and then resistant sepsis just makes things that much worse. We use this to compute the number of newborn deaths that were attributable to resistance to first-line antibiotics, and that total number was more than 200,000 deaths every year, roughly a fifth of all newborn deaths. So there's about 1.2 million newborn deaths. So it's about 1/6 of all newborn deaths are because of resistance. And newborn deaths particularly is an area we've not made as much progress as we have on under 5 mortality. It's a little harder to push on this, but resistance is one of the main things that's coming in the way. And it's made the cover of the New York Times, that particular study. And these are the ways in which it's portrayed. It kills India's babies and also poses an overseas threat. The other age group that's very susceptible to the impact of resistance is the elderly population, which, all of us were newborns at one time, but most of us will also end up being the elderly. And I can assure you that if you live long enough, you will have one of these procedures, right? All of these are procedures that everybody has. A hip replacement, a pacemaker, a surgical abortion, or a total hip replacement, or a C-section. These are all common procedures, but they all require effective antibiotics, and of course, colorectal surgery. This is the absolute risk reduction of infection with antibiotic prophylaxis in these common surgical procedures. And the trends, particularly for things like colorectal surgery, the odds of an infection probability have been going up over time. And unless we have effective antibiotics, we're putting at risk patients who go through surgeries because of the risk of post-surgical complications. And this was the estimated number of additional infections per year in the US, about 120,000 additional infections, another 6,000 deaths every year, associated with roughly 30% decreased efficacy of antibiotic prophylaxis. The other category where we never thought that drug resistance would play such a bad, would really change things so much is really urinary tract infections. I would say about 15 years ago, the risk of dying of a UTI was really small. Today, it's not small anymore, and it's not small particularly in countries like India, where it's happening with greater regularity. It's not unusual to see a susceptibility profile for UTI, which is resistant to almost all antibiotics, even if that patient themselves has never experienced an antibiotic course before. So this is really a challenge. And overall mortality in patients who are infected with these resistant pathogens, even if they're not newborns, is pretty high. It's about 2 to 3 times higher mortality. MRSA is a big problem, and especially when it is also resistant to aminoglycosides. This is a picture for resistance to gonorrhea. So back in 1920s, we had literally no drugs for gonorrhea, naturally. And today we're sort of back to the same situation where we don't have a drug that works reliably for gonorrhea. There are clinical trials going on for a drug called zoliflodacin. This is through GARD-P, this entity that I'm associated with. And this would be the first antibiotic that is actually developed explicitly for STIs. There are a couple of others in the mix right now. But overall, I would say, 70s and 80s, if there was ever a good time to have gonorrhea, which I don't think is the case, that would have been a good time. But now is not a good time. So anyway, this sort of gives you a very graphic picture of how things have changed for very simple infections that were not so challenging to treat before. New Delhi metallo-beta-lactamase. So this is obviously the cause of resistance in many of the gram-negative organisms. It started in a patient from India who was admitted to a hospital in Sweden, but it's now in most countries around the world. So the rate of spread is really fast. And really, AMR is a pandemic. It's an ongoing pandemic. All that will take is a new sort of strain which spreads really fast, potentially a respiratory pathogen. Everyone thinks of pandemics as really associated with just viruses or now if you watch the HBO series, you might think it's a fungal pathogen, but possibly not yet the case. But you have to remember, all the old pandemics, cholera, plague, were all bacterial pathogens. The reason we don't see that kind of burden anymore or that rate of spread is largely because of antibiotics and, of course, water, sanitation, hygiene, all of that stuff. But we could easily have a bacterial pandemic. In fact, there's an advisory committee to the US president, which I was part of till last month. I stepped off after 7 years. And we just put out a report on pandemic preparedness against bacterial threats. And it is a pretty serious issue, either directly or as secondary bacterial pathogens to a viral pandemic. We have to think about these things in a One Health sort of a way. MCR1, the gene that confers resistance to colistin, was first detected in pigs, but is now in the environment. It's in humans, it's in animals, and it's literally in most countries around the world where people have really looked for it. So what's really going on here? First is antibiotics do continue to be overused and misused very widely. There's a great study, this particular study from the big MALI-D study, which shows that there are about 5 courses of antibiotics per child per year, with the highest use in South Asia. This was a global study of enteric disease. And antibiotic treatment is very often given for diarrhea, where it's not indicated, and also for respiratory tract infections. So you get a lot of antibiotic prescribing that's happening here. And that's what contributes to growing use of antibiotics around the world. So we publish these every few years, which are on the increase and convergence on antibiotic consumption globally. And obviously, the first thing to note is that there's significant difference. So even if you can't see the names of countries at the bottom, you can see that there's great variation in defined daily doses, per 1,000 inhabitants per day in 2015, per year in 2015. One end is, Central America don't use much of antibiotics, and at the other end are Turkey and Tunisia, which use a lot of antibiotics. So significant difference. There's also a pattern of convergence. In high-income countries, antibiotic consumption is sort of leveled off, but the upper middle-income countries are catching up, and so are slowly the low and lower middle-income countries. So you will expect to see that with rising incomes around the world, antibiotic consumption will be far greater than it is today. In fact, our projections were that our forecast was that it would go up 3x from where it was in 2015 by 2030, with a continued growth at the same rates. But even with just convergence, and we don't think it'll just stop at convergence, it'll go beyond convergence, it's going to go up quite a bit. So we haven't seen anything yet. We've seen a lot of problems with AMR, but it's set to get a lot worse. Now, countries with the highest increase in consumption are obviously the larger countries. These are not per capita numbers, these are aggregate numbers. India is one example, China as well. But again, keep in mind, I'm only talking about human consumption. The animal consumption is a whole different story. So if you take one species that consumes the most antibiotics in the world, it's pigs in China. Pigs in China use more antibiotics than literally anyone else. So I'm not considering that here. Now, the WHO has a categorization of antibiotics called AWARE. So access, everyone should have access to them. Watch, which you should get only if you really need the antibiotic. And reserve, which really should not be used very much at all. Now, this is the change in, so the top is the change in the in the watch in the access category, and the bottom is a change in the watch and reserve. So you see in countries like India, blue, which means that the access use is going down. The antibiotics that should be used very widely are just not being used very much anymore, possibly because of resistance, but also possibly because this is just inappropriate use at work. And I'll tell you, one of the biggest things that drives antibiotic consumption is whether the pharmacist wants to sell it to you. So the pharmacist doesn't make much money on selling access antibiotics. They make money on selling watch and reserve antibiotics. I was, I had taken a colleague out for lunch a few weeks ago in Delhi. And he said, do you think we can get, like a carbapenem? I said, well, let's try. He said, what about a penicillin? I said, I assure you, you can't. So we went over to the pharmacy right after lunch and in Delhi. And sure enough, penicillin is never available at any pharmacy because they just won't make any money selling it. Ferropenem at $6 for a full treatment course, easily available. No prescription needed, you just get it. So that's really what's driving it. It's just it's just the economics of it, which is if they make money from selling that antibiotic, that's what they will do. So this is the same pattern you also see for proportional consumption of prescriptions for children with the access, watch, and reserve. And here again, you see that there are some countries that do well in terms of using most of the access and less of the watch and reserve. But here you have China, which is at this end, where the access is very little. The watch and the reserve are the bigger categories. After China is Bangladesh, Japan, and then India, Vietnam, Kuwait, and even Germany is up there. So we still are not using the right antibiotics, and we don't do any favors by giving people antibiotics that they don't really need. We have to understand that antibiotics have important side effects, and people sort of think of vaccine side effects, but actually antibiotic side effects can be a lot worse than vaccine side effects. Now, the link between antibiotic consumption and resistance is also not consistent globally. A very well-known study that was conducted by Herman Goossens and his group in 2005, basically plotted this data for Europe, and they came up with a very simple figure, which has then been reproduced in many, many talks since then, which is you have use of penicillins on the x-axis and then resistance on the y-axis, non-susceptibility. And you could draw a very clean, almost 45-degree line going that way, showing that there was some association, potentially causation, between penicillin use and penicillin resistance in a very clean way. At the one end was France, which uses the most antibiotics and has the most resistance. At the other end, the Netherlands, which has less of both. And there have been many other studies. This was from a student at Princeton who worked with me. And this was a study that very clearly showed that with a 2-month lag, use and resistance are highly correlated in US data. So easier to show. When we tried this kind of a study globally, we weren't able to find quite the same things. So in fact, use and resistance are highly uncorrelated. This is what it really looks like. It's just all over the place. If anything, it's a negative correlation slightly. But instead, resistance seems to be far more correlated with governance, with health expenditures, with GDP, with education, with infrastructure. So if you have better infrastructure, more health expenditures, then you actually see less resistance. Which sort of seems to suggest that the selection pressure from antibiotics is not the primary driver. It is how well you are able to prevent the transmission of resistant pathogens that's much more important in LMICs, just because those things don't exist. However, in the high-income countries, that transmission is to a large extent taken care of, by water sanitation and so forth, and therefore you don't really have the transmission problem as much as you have the selection and the emergence of resistance or the maintenance of resistance through selection pressure. Now, lack of access, as much as we worry about resistance, the lack of access is not just a major problem. It potentially kills more people than even resistance does, although, resistance is now, I think, caught up quite a bit. In fact, we published this Lancet series in 2015. We have another one that's coming out now. And if you can read the very bottom here, the two things we focused on are sustainable access as well as sustainable effectiveness, because you can easily deal with resistance by just banning the use of antibiotics globally. That's not the point. This is not like tobacco. Not that I'm suggesting a ban per se, but I'm just saying that this is not like tobacco, which has no known health benefits. We want to use antibiotics, but we want to use them in a way that minimizes resistance. And therein lies the problem. So this is a nice paper by Steve Hoffman, which is part of that, and colleagues, which is part of that Lancet series. Steve is somewhere here in Canada, I know. So, there's access for millions of people without antibiotics, there's conservation of existing drugs, and there's innovation. These are the three sort of legs of the stool. These are the things that we can really do. And, access without conservation and without innovation will just speed up resistance. So you can't just continue this agenda without doing the rest. Just doing conservation, which is preventing people from using antibiotics or making them use it more rationally, does constrain access. Whether we like it or not, it does constrain access. And it undermines innovation. Why does it undermine innovation? Because if you're going to allow fewer sales of an antibiotic, no one wants to make that antibiotic. Whoever wanted to make something where the use of it is constrained. And meanwhile, innovation without access is unjust. It's just not a fair thing to do. And it's also not useful to do without conservation. So we need all of these three things together, but this sort of summarizes the challenge that we have in putting these pieces together. Now, we also have to recognize that a lot of people don't have access today. Like I said, I showed you the other picture showing that pneumococcal pneumonia is treatable with penicillin. And penicillin, this is the same picture. Penicillin is effective, but not widely available. In fact, you can't get it in many LMICs. And this was our estimate of the avoidable pneumonia deaths avoidable with improved antibiotic access, and it's quite a significant number. So we really don't want to constrain access, but there are places in the world where access is too easy, and there's places in the world where access is too difficult. And we need to sort of sort out what we're doing between those two places. Now, why are antibiotics overused? Let's first start with what we're asking of antibiotics. This is a very nice paper by Armstrong. It's been updated since then, but this picture is a good one. It shows crude infectious disease mortality over the previous century, starting from about 800 per 100,000 per year and coming way down. You can see that the first use of, I don't know if I have a pointer here. Oh, there it is. Okay. So it comes down all the way to the 1940s where penicillin is introduced without the use of antibiotics. So infectious disease mortality came down, not because of antibiotics, it came down because of public health, water, sanitation, hygiene, all that stuff. And then after that, it helped go further. And then, of course, vaccines come in and it bumps back up a little bit because of HIV. But the message is that this is what brought down the use of antibiotics. In South Asia, today, the crude infectious disease mortality is more than twice what it was in the United States in 1942 when antibiotics were introduced. So that's in South Asia today. In sub-Saharan Africa today, crude infectious disease mortality is 3 times what it was in the US at the time that antibiotics were introduced. So what we're doing is we're using antibiotics as a substitute for public health, water, sanitation, hygiene, rather than in addition to. And this is, the analogy is like you're trying to mop the floor with the tap still running. You'll never be able to do it. And unless we invest in all that other stuff, infection prevention, control, vaccination, all the ways to reduce the need for antibiotics, we really can't deal with it in this way. But this is precisely what's going on right now. And it's a huge issue because, the antibiotics in some ways have disincentivized infection prevention and control. We're doing a big study in Tamil Nadu, which is a, pretty good public health system in India. And something like 85% of newborns in the 93 birthing hospitals that we're working with are all put on antibiotics prophylactically as soon as they're born. And you can imagine the kind of resistance that generates. But the doctors do it because, it saves the baby or it helps them not at least for now, it sort of protects them from infection. But the right answer there is to have the infection prevention in the hospital so that you never have to use an antibiotics in the first place. Remember that resistance per se is not the problem. You can have 100% resistance to a pathogen, but if you have no infections, you don't really care. In fact, I would rather have one case and 100% resistance than to have 10,000 infections with 20% resistance, because you'll do more damage that way. So reducing the number of infections is still what we really need to go after. Now, the incentives for antibiotic prescriptions are still pretty crazy all over the place. In China, because of history and how hospitals used to be funded, hospitals derive significant revenues from the sale of antibiotics. They essentially allowed to charge usually for drugs and for diagnostics. And of the drugs, antibiotics are half of what they derive from the drugs. So it's a significant proportion of hospital revenues. Trying to minimize prescription there is very difficult. In India, it's sometimes just a matter of not knowing the right thing to do. Many facilities will have the watch and reserve antibiotics, but they wouldn't have ordered the access antibiotics because they'll say, oh, I have some antibiotics in stock. I'll use all of that before I order the next lot. So these are things that can be improved. And of course, the fact that many people don't have medical degrees, and I'm using India as an example, not because India is the only country that has these problems. It's because I do much of my work there, and this is what I'm more familiar with. But these sorts of things you see, whether in Kenya or in DRC or anywhere else. The incentives of patients are also not aligned typically in insurance models or a privately paid system, because mostly physicians are trying to satisfy patient expectations. There's a lot of studies, literally when I say a lot, probably 500 studies showing that when patients expect an antibiotic, they get an antibiotic. And even if the clinician believes that a patient expects an antibiotic, they will get an antibiotic. I, in fact, forgot to put in a study here. Can anyone tell me what the single most important determinant or driver or predictor of an antibiotic prescription in a particular zip code? I imagine you have zip codes here. So what do you think the single most important predictor? It could be race or age or gender or social status, whatever it is. Any ideas? Absolutely. It's a number of doctors in that zip code. By far, it's one order of magnitude more important. And this is true for data in the US, it's true for data in Taiwan, and I suspect it's going to be true in many places. So just pure competition, the idea that if you don't get a prescription from this doctor, you can go to another doctor and get it, is really important. Actually, many years ago, we did this very interesting study where in the US, in the Midwest, there was a pharmacy. There was a grocery chain called Meijer. I don't know if you have it here in Canada. They have it in Ohio, MEIJER. And one fine day, this grocery chain said, we're going to make a certain set of antibiotics free for anyone. Of course, if you have a prescription, because it's just a loss leader, as they call it. You get footfall into the store with the free antibiotics, and then you sell them all the other groceries. Guess what? It actually changed the prescribing habits of doctors. And we had very good data because we had data for people living close to the Meijer stores versus not, and we had before and after. And basically, doctors switched the antibiotics that they were prescribing from other antibiotics into the ones that the Meijer stores were providing free of cost, and overall prescriptions just went up. And interestingly enough, there was also an income gradient here. So this happened more for lower income households or those neighborhoods because obviously they're more price sensitive. But it isn't as if doctors are writing prescriptions in just the right thing that's required for the right patient at the right time. That's what this should be doing. Instead, they're obviously very influenced by what's going on in terms of economic incentives, what the patient is telling them they really ought to do, and those expectations are very important. Decision fatigue, big reason for inappropriate prescribing. So if you want to get a prescription from a doctor, and I suspect this is not just in the US, this was a US study, is you go in the afternoon. Why? Because in the first hour of a session, they're less likely to give you an antibiotic because they have more energy to explain to you why you don't need an antibiotic. But by the last hour, they're just like, well, just get out of my office and here's a prescription. This is not just for doctors, by the way. It's also for judges. So you're more likely to get off for a traffic ticket or a fine if you go later in the day. So use that information well. This is what economists do for a living, right? Yes. Oh, did somebody have a question? No. Right. So, and this is a study that we did in 6 of the best facilities in the US, 6 of the best hospitals in the US. And what we did was we did a whole bunch of chart reviews looking at an index day when a patient got an antibiotic, and then looking back to see if an ID fellow could figure out why they got that antibiotic just looking at their charts. You know, did they have a sign of infection? Did they have a fever, abnormal white blood count? And at the start of therapy, 30% of patients, the reviewing doctor could not figure out why that person had ever been put on an antibiotic. They just had no signs of infection whatsoever. Now, appropriate cultures were collected from 59% of the patients. You can flip it the other side and say 41% never got a culture. So they just continued on the antibiotic without any culture at all. These are all inpatient, obviously. And by the 50th therapy, 12.5% of empirical antibiotics were escalated, 21% were narrowed or discontinued, but 66% were just unchanged. So cultures should change the antibiotics that patients are on, but doesn't really appear to be the case. So we talk about diagnostics. We say, oh, but diagnostics are really the solution. If we had better diagnostics, faster, cheaper diagnostics, life would be so much better. That's not what the evidence suggests. The evidence suggests that doctors don't really respond to the diagnostics very much at all. Again, these are human factors, right? No one wants to change the prescription of the patient when they were not the ones who wrote the initial prescription and take the risk that something wrong happens there. So it's if everyone's covering their butts this way, then it's really the patient that suffers at the end. And of course, narrowing or discontinuation is more likely when cultures were collected at the beginning. It's not to say that stewardship programs can't work. This is a study that just came out last week showing that a multifaceted program can reduce prescribing for urgent care encounters for respiratory conditions. Now, this is an Intermountain Care, which, you know, the best studies in the US will all come out from Intermountain Care because they can do amazing things. They have a full capture. They're a very empowered kind of a health system. But this is not true across the US. So education, electronic health records, transparent benchmarking, and media can all help. So the first part of it is the baseline, then it's the intervention rollout in the middle, and then the sustainability, which is very important afterwards. All looks very good. But this stuff doesn't seem to work in other countries. So much of it is because of the history of stewardship. I don't know what it was in Canada, but in the US for sure, a lot was driven by the need for cost containment. It was not really about antibiotic resistance. The hospital didn't want you to put the patient on a more expensive antibiotic because under the diagnosis-related code, the diagnosis-related group system in the US, Medicare would not pay for more than a certain amount for that patient. Of course, drugs were not included unless it's inpatient. But mostly it was cost containment, and they're resource intensive, and they worked as an adjunct to IPC, not as a replacement. But in most LMICs, the antibiotics are really a replacement for infection prevention and control. And the question is this the right model for LMICs when access is often an overriding issue? And the hospital incentives are really that antibiotics, even in the US, are a substitute for infection control. And infection control is not compensated. So what do hospitals do? They rely on what is actually compensated. It's actually a bit worse than that even, because there's this great study from Atul Gawande's group at Harvard. These are data from South Carolina, I believe. So they were looking at surgical complications and how well the hospital does financially. Now, these are not problems you have to deal with in Canada, of course, but in the US, if the patient has a complication, the hospital makes about $40,000 more as a contribution margin per patient. And even if it's a Medicare patient, they make about $1,800 more. So not only is there a disincentive, not only is there no incentive to do better on preventing infections, you actually make money if the patient has an infection. And a lot more money if the patient has an infection. I'm not suggesting that, that US hospitals are deliberately infecting patients, but let's just say that they're not terribly incentivized to reduce them either. Antibiotic restrictions. So this is a very nice study from Taiwan, which looked at a policy to not hand out so many antibiotics in the public system. But guess what happened? After the intervention, particularly for some kinds of antibiotics, the prescriptions went up in the private system. So if people couldn't get the antibiotic in the public system, they just went to the private system and got the antibiotics. So just to say that unless your public system covers the entire country, or there's a coordination between the public and the private system that works together. You can't just do one or the other. Now, the obvious other piece is the non-prescription use of antibiotics. I know a lot of people are very concerned about it. To me, the fact that per capita, the US uses far more antibiotics than India, where you do get over-the-counter easily without a prescription, means that physicians are not necessarily good stewards of antibiotics. It's not like just plonking a physician between you and the antibiotic gets you the right outcome. So I know everyone belly aches about this part, the non-prescription use of antibiotics. What's really going on here is that many people don't have access to a doctor. This says clinic, but that person who's supposedly running that clinic, not those two children, by the way, they probably have been a ward boy for some doctor for 2 years, and then they've opened up their own clinic. They're not medically trained. But what they do try to do is try to imitate what the doctor would do. So they're not entirely trying to kill patients either. They're trying to do the right thing, but obviously with zero medical training, which makes it a little difficult. And it's the case because doctors and nurses are just not available in the same numbers. In China and India, it's about 1 to 2 doctors or nurses per 1,000 population. Even in South Africa, which is still a middle-income country, it's 4.7. And of course, the UK or the US would have far more. So simply mandating that all antibiotics go through a prescription from a doctor would just be grossly unfair and unimplementable in many of these countries. It would really constrain access. So we need to think of ways in which we can figure this out. That said, stewardship and conserving effectiveness is worth a lot. So this is an older study which we looked at a 1-year delay in the need for a $3 billion antibiotic investment. And if you can push back that need for that investment, that's worth about $300 million a year, which you could be spending on stewardship. Now, the healthcare system doesn't get that money, but the society at large does get that $300 million. But we don't spend anything close to $300 million on stewardship in any country in the world, not even in the US, which spends today about $2 billion a year, every year on AMR, up from $5 million in 2015. But we don't spend this kind of money on stewardship. And we should, because otherwise we'll be paying the cost in a different way, which I'll show you. Now, vaccines. So this is an area of a lot of recent work that we've been up to. And I think vaccines can really play a significant role in reducing antibiotic resistance and consumption. It's a fairly simple metric. You have fewer infections, you have lower disease burden, less transmission, you save lives. You also have less antibiotic use, which also reduces selection pressure, and that also works in saving lives. We have a lot of evidence on vaccines. So this is a study back in 2006 associated with the introduction of the pneumococcal conjugate vaccine, PCV7 in the US, which reduced both susceptible disease and non-susceptible disease. Actually did it both in the target population of the children, but also in the above 65 who were not given the vaccine. So it has effects across age groups as well, to the point where prior to 2012, the single age group in the United States that got the most antibiotics were kids under the age of 5. In 2012, that switched, and it's no longer that age group, it's the elderly population. And I would say almost entirely because of this one vaccine. Prior to, I guess, 2000, a lot of children had, ear infections if they went into to daycare and stuff. And a lot of that really went down with the conjugate vaccine. And in fact, antibiotic prescriptions attributable to acute otitis media decreased almost 42% after 2000 because of the vaccine. So this is a huge set of papers that are now available. These are all written in the last 3 years on the effect of on antibiotic use and resistance on various pathogens, typhoid, Shigella, rotavirus. Now, some of these are viruses, and you'd say, well, what's the antiviral vaccines doing here? It's because the viruses are the ones that really drive a lot of the antibiotic prescribing, and I'll show you that in just a second. So let me talk about PCV first, because the stuff I showed you was from the US. This is the global evidence now showing that pneumococcal infection causes about 56 million antibiotic treatment episodes every year globally in children under 5. And we could really reduce that by another 22 million antibiotic treatment courses if we had PCV vaccines scaled up. Rotavirus vaccines, similarly, large numbers of antibiotic treatment episodes and universal coverage of the rotavirus vaccine can also help reduce antibiotic prescribing a significant amount. This is the typhoid conjugate vaccine. Now, multi-drug resistant typhoid has now become the reason for introducing a vaccine in countries. Today, Zimbabwe, Liberia, and Pakistan all have a typhoid conjugate vaccine introduced not because of the underlying just the disease burden. The fact is that they all have multi-drug resistant typhoid that was simply untreatable. And so the vaccine is not just it's not a nice to have. This is the only way in which you can deal with typhoid in these countries anymore. And we estimated about 342,000 deaths from MDR typhoid that could be averted through scaling up a typhoid vaccine. This is RSV, respiratory syncytial virus. And we were looking only at children. These were data that we'd collected in the context of a clinical trial where there was obviously the intervention in the placebo arm for a vaccine that was developed by Novavax. Now, that vaccine didn't meet its clinical endpoint, so the vaccine is not going anywhere. But there are 3 or 4 other vaccines that are now in play by Pfizer, GSK, I think even Moderna. Many other companies are coming up with RSV vaccines. RSV is a big driver of antibiotic consumption around the world. And in this particular study, you can see a small sliver of a change between the intervention and the control in terms of prescriptions. But when you really add it up, it ends up being a lot. So the intervention arm infants had almost a 13% lower incidence of prescribing of antibiotics in the first 3 months. Vaccine efficacy was associated with lower respiratory tract infections, so it reduced by about 17%. And maternal vaccination prevents about 5 courses per 100 infants in LMICs, representing almost 11% of all antibiotic prescribing. If we could cut 11% of all antibiotic prescribing with one vaccine, that's something we might want to really consider. Now, influenza. This is the peak month consumption of antibiotics in the world. It has nothing to do with influenza, by the way, this picture. It's just peak month consumption of antibiotics. Now, doesn't require much epidemiology or anything else to show that the peak month consumption is January and February, or December, January, February in the northern hemisphere, and is June, July in the southern hemisphere, simply because that's correlated with the flu season. It's not just a hypothesis. We wrote this paper many years ago showing that if you had antibiotic prescribing data by zip code, which we did, you can almost perfectly predict what the influenza rates are in that particular zip code. It's almost perfect. These sit on top of each other. You can't even tell that there are 2 curves going on there. And in the US, influenza data doesn't get, or ILIs, influenza-like illnesses, doesn't get reported very promptly. Like California reports it 1 year after the flu season. So if you want real-time data, people used to use Google Flu Trends. But you don't need that. Just use the antibiotic prescribing data. Now, obviously, you all know that this is not the way it should be. This really is a tight fit that is extremely worrying. But it just goes to show how much of influenza is also correlated with antibiotic prescribing in the United States. And if we had the seasonal flu vaccine much more widely used than it is right now, and if we had better seasonal flu vaccines, then we could really take a big, big bite out of this. Last few slides are around public campaigns. Do they work? Yes, they do. And they've been around the world. Antibiotics, misuse of antibiotics putting us all at risk. WHO, again, going back to a US example, the fact that people found out that antibiotics were being used in raising their chickens really triggered this whole change where now there's a move from companies to say that we don't use antibiotics. In fact, Purdue Chicken, as you can see in the bottom, Purdue, right up to the point of this particular advertising campaign, freely used antibiotics in their chicken, in their poultry raising. But once the consumer preferences changed, they went to a no antibiotics ever kind of a model. Doesn't mean that they actually don't use antibiotics. What it really means is that they don't use antibiotics for growth promotion. If there is a disease outbreak and they have to use the antibiotics, then they ship off those chickens to some other label and it comes out from somewhere else. They just don't sell it under the Purdue label. I knew there was a glitch there, right? So And France is a good example where the antibiotics are not automatic campaign, which has been strongly associated with a reduction, almost 26% reduction over 5 years. So there are good examples of this. I'm just going to give you a couple of slides on the climate change related stuff. I don't know if anyone's working on this, but this is a study actually that just came out yesterday from a student I was working with at LSHTM, and this is looking at antibiotic resistance drivers. And there were significant associations between antibiotic consumption and AMR in food-producing animals, and also between human consumption and AMR specifically in the WHO critical priority and high priority pathogens. Climate change, important. Gram-negative bloodstream infections are associated with higher temperature. We don't quite know why, but this is important and worrisome because we would expect that with warming parts of the world, we should expect to see more of the gram-negative infections. In fact, there's a very nice paper which looks at this across many studies, and there's a very strong positive trend between the minimum temperature and resistance. So this is an area for a lot of work, and of course you see resistance genes all over the place from environmental sites, gone up a lot since when we first started looking for these. Now here really are the last few slides. The pipeline of new antibiotics has improved. So this is the left side is what we had in 2013. This is what we had in 2019. So you can see that the drugs that are in phase 3 or in application or approval, there are more. They're not necessarily novel. But there's a few challenges. The new drugs don't always reach the populations that need them. In fact, only 12 of 21 new chemical entities that were entering markets between 1999 and 2014 were registered in more than 10 countries, which means new drugs are typically sold in North America, Europe, or Japan. That's it. They don't go to any other country. So the whole development of new antibiotics is not really affecting the rest of the world. There's also, although the trend has not been great, 61 of the 61 new antibiotics approved between 1980 and 2009, many of them were withdrawn because of toxicity or lack of market. And that's compared to a 13% withdrawal rate for other therapeutic categories. Antibiotics are actually difficult to make, and it is a tough category to deal with, and also high cost of clinical trials and so forth. So it is a challenge that we'll have to deal with, but I'll leave you with this last thought, which is, what is the future we're headed into? 1941, penicillin was introduced. Still costs about 10 cents a dose. I know you'll get it for free in Canada, but in the US, if you got a prescription for penicillin G, your copay will be 50 cents, and the cost of the penicillin is 10 cents at a CVS or a pharmacy. That's all it is. It's 60 cents total. You're paying 50. The insurance company is paying the 10. Linezolid, introduced in 2000, $155. Daptomycin, about $181. Now, daptomycin sold for a lot more money when it was first introduced. It sells for less now because it's off patent. Cefiderocol, which is a drug that is made by Shionogi, sold in, I think it's approved here as well, which GARP now has the licensing rights for the rest of the world. But in the US, I checked last week, the price of that drug is $4,800. So you're doing with $4,800 what you could do before at 10 cents. Now, that's not the end of the story, right? There are drugs, this is not an antibiotic, this is an anti-cancer medicine that just extends your life by 3 months. And people are willing to pay $31,000 for a cancer drug that extends your life for 3 months. How much would people really be willing to pay if it's a life and death situation for a drug that will take you to your natural lifespan, not just for 3 months? $100,000, $500,000 could be huge, right? But the question is, do we really want to be paying, even $5,000 for a treatment of antibiotics, which we could have paid 10 cents for? Antibiotics are really the only technology, so to speak, where the cost per treated patient has been growing at an exponential rate over the last 30 years. There's almost nothing in that space in your experience, right? Your cost of a computer by either by memory or by megaflops, all sort of decreasing. Everything else in our lives is decreasing in cost. And this alone is going up at a massive rate because we're using up the effectiveness. So, however, we do need to sort of think about ways in which we need to improve access in other countries, and and companies can make money if there's a way in which we can justify the entry into the market, because most of the patients that need are most in those countries. So here's my last slide. This is from 1899 from Athens, Georgia. This poor man was an athletic director of the YMCA. He suffers a loss of his right foot because, it's amputated because he was exercising in the grass, small cut, sepsis sets in, and obviously there were no antibiotics back then. I never thought we would be back in those situations where this could happen, but we actually are now back in the situation where this happens. So I'll stop here.
So we have some time for questions. So maybe I'll start. You showed a lot of data that came from low and middle income country mortality attributable rate. And of course, when we're thinking of Canada, North America, patients are different. In some ways, they're more vulnerable. Okay, how do you project the risk, the mortality, the morbidity for countries like Canada with regards to rising AMR?
I think there are estimates, but obviously it's lower because the underlying burden of infectious disease is lower. So it's easier in that sense. But Canada is as susceptible as any other country to a sweeping in of a bacterial pathogen that spreads very quickly and which is not treatable with existing antibiotics. So I don't know how many of you heard about this case that we had in the US of this easy tears, an artificial tear that was imported from India, which came in with Pseudomonas aeruginosa, which was untreatable with any antibiotic except for cefiderocol, the one I showed you just now. So you have these situations where stuff does travel around the world very, very quickly. Could that have happened in Canada, or perhaps even happening in Canada, because those easy tears probably got here as well? It's the most widely used artificial tears in the world, or at least in North America, I think. It easily could. So I don't think we're quite capturing what the burden is in a complete way.
Thank you very much. This was a really, really interesting and great talk. I come at it from the perspective of antimicrobial stewardship. And I was wondering if you predict or if you are aware of a metric where we could, for the individual doctor, give them a number needed to harm. Because a lot of doctors will feel that, yes, they understand the societal harm, but not at the individual level. So that actually drives a lot of unnecessary prescriptions, because if it's perceived as harmless, and we actually don't have a good metric for individual antibiotics to be able to provide a number needed to harm at the individual patient level.
That's a great idea. I hadn't really thought of it. So I think US CDC has been trying to put out public messages to doctors saying that don't forget that unnecessary antibiotics harm the patient. We also have, I didn't show this, but there are lots of studies showing that an individual patient is at greater risk for resistant infection if they themselves have been put on antibiotics. These are just poorly publicized and understood. So you're 100% right. We haven't focused on this idea that, in fact, we had this study a few years ago, which was derailed by COVID. We started in 2019, not a good time to start any study. But we were looking at why pediatricians, or why parents of young children, especially under the age of 1, perceived vaccines to be dangerous, but perceived antibiotics to be safe. Completely, uncorrelated with the evidence. But, there's a lot of psychology and norms and all of that stuff involved there. So, but it's an important area, I think. Thanks for raising it.
I think a credible metric would be, and then if I may, maybe another question, which is more towards the end of your talk. You talked about the cost of antibiotics and how, they've been inflated over the last decades, and yet we have accepted the cost of cancer treatment. And I would ask you, should we spin it around, and should we be saying that antibiotics should cost a lot more, which would force practitioners and patients to think about it before? I wonder if the harm has been that they've been too cheap.
Great point, really great point. In fact, a lot of people don't like that point to be made, because who wants antibiotics to be expensive? However, the way in which this works is that everyone is doing the dumb things, and therefore it's going up. So it's not like we have options, we're all in it together. So you can't save money because you did the right thing if I do the wrong thing, right? And also within countries. So this truly is a global public good. In fact, my next slide is usually on climate change because it is like climate change. So in a world in which individuals could make decisions, or individual countries or systems could make decisions rationally, they would look at that escalating cost and say, I want to change my trajectory of how I'm doing things. But this problem that it's a global commons, so to speak, is preventing that kind of a thought process. But you're 100% right. And the other part to remember is that only few people get cancer. Almost everyone gets a bacterial infection almost every year. So we are talking about situations where it's the cost to society of treating bacterial pathogens is just going up really fast. And the question is, who's going to put a brake on it at what time? And I was in a conversation with someone at the Ministry of Health in India a few weeks ago. They have no interest in stewardship because they said, oh, but if there's a resistance problem, we won't be blamed for it. But if I restrict access, I'll be blamed for it. So that's how the 5-year political cycle works.
Any other question?
So towards the beginning of your presentation, you showed that Germany was on the right side of the spectrum. So what is Germany doing that we are not?
Remember, it's a combination of a few things. It's a burden of infections. It's also access to newer antibiotics. I think Germany has, strong stewardship programs. They certainly pay a lot of attention to it. I think that's what they're primarily interested in. They also have very strong IPC programs. I'm not as familiar. I know the German system better than I do Canada, unfortunately, which is a bit embarrassing because I'm just from south of here. But the Germans have a very sharp focus on AMR because it's been a real challenge for them in hospitals for a while, and so they've really pursued it with a significant amount of attention. Canada actually has a big problem on the veterinary use of antibiotics. It's something which is very hard to make progress here. In fact, the biggest pushback we get often in international fora on restrictions on antibiotic use in animals comes from Canada. And not surprising, it's a big livestock sector, but at the same time, I think there's an opportunity to think forward and reduce consumption of the livestock sector with vaccines or more modern sort of livestock rearing methods. But there is obviously, like I showed you in one of those, the Qasim Alal's paper, that these are correlated. It's what's happening in the animals is also affecting us. So that's possibly one place that Canada could do a lot better on.
Thank you so much.
Hello, thank you for the great talk. So I wanted to ask a question about the correlation between use and resistance. So earlier in the talk, you showed the map where we didn't have all the data from all the countries, and then the global study on use or correlation between use and resistance said that they're not supposed to be correlated in a sense. So in a world where we'd have data from all the countries, all the world, would this metric change? Would we find increased correlation? And is the correlation also between use and resistance antibiotic class specific, or it's for all antibiotics? It's true for all antibiotics.
Great question. I think that if I were to guess, I would say it's not going to be as strongly correlated globally as it is in high-income countries, just because all those other metrics that affect transmission of drug-resistant pathogens are also playing a very strong role, right? So it's not just selection pressure. If you don't have a good water and sanitation system, if you don't have chlorination, if you don't have good public health, then the antibiotic consumption alone is not doing all the damage. All that other stuff is doing the damage. That's the reason why I don't think that correlation is going to be as tight. Does that then mean that we don't care about consumption and we continue using antibiotics the way that we want? I don't think that's a good answer either. So, but it's just to keep in mind that the first things we would focus on in LMICs, that I would focus on, is really to reduce the need for antibiotics in the first place. And that's why I put the vaccines up there as being a major thing that we would do, and also water and sanitation, hygiene, although we have less evidence there, and then infection prevention control. So I know that's not a direct answer to what you were asking about, but I think that's how I think about that sort of correlation. Sorry, your second question was on different classes. Actually, it is different. So there's a whole bunch of mechanics that maybe Dow can explain because these are microbiology things. The fitness cost of resistance plays an important role in terms of what kind of trends you see there, because sometimes you reduce selection pressure and you have a high fitness cost, you'll see resistance sort of decrease as well, but you won't see that for all bug drug combinations.
One more question?
Thank you so much. It was a really good presentation. I just wanted to ask that you mentioned that antibiotic usage and resistance were like inversely proportional kind of thing in many countries. Is it possible that the low-income countries who the people in day-to-day life are exposed to these pathogens through their environment and maybe become resistant, and the antibiotics, when they are used, they don't really affect them in that way?
So remember, the resistance is of bacteria to the antibiotics. Are you referring to human sort of immunity?
Like you mentioned, vaccines are a good method that they can use to avoid antibiotic resistance. But people in low-income countries are very exposed to these pathogens because of poor sanitation and hygiene. So is this affecting their level of infection rate or something like that?
No, I think they get a lot of infections. That's why they get a lot of antibiotics as well.
But even when they are subjected to infections in general, the pathogens, they're still getting a lot of infections.
I don't think exposure to pathogens is a way of reducing infections. Typically, it increases infections. So they're getting infections all the time. In fact, a lot of the reason why we have malnutrition in many parts of the world is because they're constantly subject to enteric pathogens that are affecting the ability of their gut to absorb nutrients. So I don't think there's any world in which we want to advocate, more infections as a way of, solving the problem in some way. Infections don't, it's obviously a nuanced story. There's some parts of it which are things like, I didn't get into it, but there is antibiotic exposure as well and what it does to your immune response. That's a different piece. So, for instance, early antibiotic exposure has now been correlated with childhood obesity, with irritable bowel syndrome, with childhood asthma, and all of that, because every time you take a course of antibiotics, you're basically nuking your commensals. And there are many commensals. Remember, there's a very, very, very small proportion of bacteria that harm us. The vast majority are actually useful to us. So the idea of the war on bacteria is kind of stupid because we are mostly bacteria. So if you're interested in that, there's actually now a new documentary as well. I'm blanking on what that's called, but it features Marty Blazer, and the book is called Missing Microbes. And you might want to read Missing Microbes. It's a really good book. And this is a major piece of the antibiotics puzzle, which is that many infections, that we see today are potentially because children got antibiotics in large numbers very early in their lives. So it's not a resistance problem, but this is other sort of effect of antibiotics. This is obviously I'm trying to compress a lot into an hour, but I won't ramble.
Thank you so much.
Yeah.
So with this, thank you very much, Ramanan, for a fantastic keynote speaker. And so with this, I'll just take 2 minutes to, first tell you that, in next year, the AMR Center, along with Dominique Frigon as a chair, will be hosting, there you go. We'll be hosting EDAR 7, which is the Environmental Dimensions of Antimicrobial Resistance. So this is an international conference that started in Canada back in 2012, and now is coming back to Canada and will be in Montreal next year. And this is really a conference that brings together grassroots, scientific, regulatory, policy communities that are concerned around AMR, for that, particularly looking at the AMR ecology, the biology and the environment, the surveillance approaches, the risk science, economic and behavioral dimensions. So stay tuned. All of those of you who are interested in getting involved, come see Dominique Frigon. And with that, lunch is awaiting you. And please come back at 1 o'clock for our next joint presentation. Thank you.